but we have several partner institutions, St. Luke's, UMKC, KCU, uh, let's see, KU Lawrence, K-State, Children's Mercy Hospital. I think I included all of them. Let me turn my transcription off. My name is Sharayla Haynes. I am the Community Partners Project Manager here at Frontiers, our clinical translational science institute. And we have put together this group of people that are including community members and investigators so that we can not only talk about best practices and community engagement, but also to provide a network and a place for people to connect dots that maybe they didn't know existed, and those synapses that are firing in their brain, and how we can get people to work together to do team science in real life. Okay, so I like to do this intro because these are recorded. They go on YouTube. And so for people that watch them that may not be aware of exactly what we are and what we do, now they know before we can begin. So thank you for listening to that. Those of you that come every month, thank you for listening every month. I appreciate it. A couple of quick announcements. And Alan, if I miss anything, please let me know. A huge thank you to everyone that participated in our quarterly meet and greet. This week on Tuesday, we traveled to Lawrence to the Cider Gallery, and we had a really good turnout there. I was really pleased with it. Some of our Kansas City folk, we rented a Sprinter van and we rode down on the van together. So there was networking done there, as well as when we got to the Cider Gallery, and there were people from Lawrence and surrounding areas, and even some Kansas Cityans decided to drive on their own, which was really nice. We celebrated Mental Health Awareness Month, as well as Asian American Island and Pacific Islander Heritage Month, and we talked about some health disparities. We got a live performance from a beautiful performer, Kawisi, and it was just a really good time. I have some survey results I'll be sharing with the group once I can analyze those soon, just about how that went. Our next meet and greet will be August 13th, and it should be on your calendars already, but it will be at the Bethel Neighborhood Center. We have Mong on the call right now, and they have remodeled their neighborhood center. So I'm super excited to go and see all the remodeling that they've done and meet with you all in person. So the meet and greets came out of COVID, when we were all forced to be virtual. And so we knew that there was a touch point needed for people to meet in person. And that's where the MARG in-person meet and greets came from. And they've been incrementally having more and more people every time. So we hope to continue to grow that program. Another thing I just wanted to announce, we are still officially recruiting for our community advisory board. As mentioned, we have rebranded our previous community advisory board, and we're trying to really tackle the issues that the community sees that we need to focus on as investigators and as researchers. And so anyone that you know, whether they have experience or not, if they're just interested in how research happens, if they were involved in a clinical trial and they're like, this is interesting, how do they decide to do these? Please send them my way. I will drop a flyer in the chat at some point during this call, and you'll receive it via email as well. Alan, am I forgetting anything? Any announcements?
I don't think so. I think you covered it good.
Those are our two main ones. Oh, last two. If you notice on your calendars, this meeting, which is the third Thursday of the month, of each month, it will end in June. So I'll start the recurrence again. If this time works for everyone, I will send a quick poll out via email. If this time does not work for the majority of people, then we'll find a new time. But if it seems to be fine, we'll keep it. I'll extend the recurrence and we'll continue on that way. We already have some speakers loaded for next year that I'm really excited about. And that's just another plug-in for you. If you know of someone that you think we would benefit from hearing from, please don't hesitate to send them my way. Even if one of the sessions that we have doesn't work, we can always try to find some ad hoc time, or maybe push it out to the next calendar year, because we already have people booked for January of next year. So just like with our speakers today, we have I've been anxiously awaiting to hear about this for about a year now, because it didn't work on their schedules. And so that's exactly how it works. It's still relevant. The research is still relevant. The work is still relevant, and we can still learn from it and take these pieces back to our own communities and back to our own research. So we do have some speakers, but if you know of any, please send them my way. I'm always happy to take suggestions. So you should be receiving an extension of these invitations soon, once I send out a poll to make sure that this time still works. Okay. I think that's it. That's it. That's all, maybe. Oh, also, let me just say, if you have any announcements for community events and you have a flyer you want to drop in the chat, please do so. There should be time at the end of the meeting, maybe 5 minutes or so, if you'd like to talk briefly about what your event is, if you're recruiting or if you need people to help man the event, you need volunteers. This is the space to do that as well. So feel free to do that. Okay. I am going to turn it over to our speakers for today. So Telehealth Rocks Overview and Partnerships is the title of this presentation, brought to us by Robert Stiles. He has an extensive leadership experience with primary medical, dental, and behavioral health services in the community setting. He has advanced a number of transformational initiatives to meet child and family needs in rural schools, including directing the Telehealth Rocks and CanAware programs through KU Pediatrics. He has a master's in public health from KU Med and teaches popular KU Lawrence courses. Also, Eve-Lynn Nelson, PhD. She is a pediatric psychologist and professor in KU Pediatrics. She pioneered school-based behavioral health from 1999 to now. That is quite a lot of time to know, and how many changes have occurred since then. She leads a $17 million grant portfolio, including Telehealth Rocks, CanAware, school-based programs, and Heartland Telehealth Resource Center, a federally funded center advancing telehealth best practices across Kansas, Missouri, and Oklahoma. As it says in our invitation, we have two guests with us as well today, and I will allow them to introduce them as they go on. So please, I'll turn it over to you. Thank you so much for joining us today.
Thank you, Sharayla. We're so excited to join the group. I just want to let you all know I can only see one person on the screen, so I just really encourage folks to speak up, and I'm not going to be able to see on screen. So please, as you have thoughts and questions, please chime in. I just want to start off saying we were thinking this would be really great timing with Mental Health Awareness Month, but I had not appreciated what a busy month May is. It always sneaks up on me a little bit. And so I'm just grateful for everyone who's joining today. Of course, all the MARG group, but our partners too. I know we were talking right before this started about how it's the end of school. It sounds like Aaron and I have graduating seniors too. So with that and Mother's Day and weddings and other milestones, I just appreciate folks taking time to join us today. I just wanted to give an overview of what we're hoping to talk about. I see many familiar and friendly faces online. So many folks we worked with as part of Telehealth Rocks, our school-based telebehavioral health program. But I want to give an overview of some of the work we're doing. The program's really evolved over the last 8 years. So kind of talking about some of the newer work that we're fortunate to be doing with partners. Then we want to make sure we're spending the majority of our time talking with our community partners, really hearing from them how Telehealth Rocks has fit within broader community priorities and initiatives. And they really have been our leaders in starting some of this similar work early and sustaining work that it's partly Telehealth Rocks, but it's the bigger picture of all that they're doing around school-based mental health and broader community initiatives. So just say we really want to prioritize that time. And then we really want to hear, of course, the MARG group questions as we go through and as we talk about partnership. And then there's a bonus in the conclusion, so I'll kind of keep that till the end. So I'm excited to share it at the end. I'm going to talk about what draws us to this work in school-based mental health. Again, this is a pretty brief overview. I know I'm often singing to the choir with many of the folks that I'm seeing online. Just acknowledging that we really have seen a concerning increase in child behavioral health concerns. And even the most concerning endpoint was suicide increases, even among our younger children. We're seeing really elevated rates and continued elevated rates post-pandemic of depression, anxiety, trauma, loneliness, and suicidality, really impacting, of course, the child, but then really impacting everyone in that child's world, impacting their family and loved ones, impacting their school family and those caring adults and other children and families, and impacting their whole communities. We see that the rates of these behavioral health concerns are more at risk with more marginalized, minoritized populations, and especially youth in our rural communities are more at risk for some of these concerning outcomes. With that, we see that I'm speaking to Kansas. I know that we have some folks across Kansas and Missouri. There's some similar concerning rates in Missouri as well. Kansas ranks last in overall mental health access and second to last in child behavioral health access. A lot of that's driven by distances to care and real workforce shortages. And we'll talk a little bit about that. Was sure the reason for starting some of the Telehealth Rocks work and looking toward telehealth to bridge some of those gaps. But then the work has really grown from that more to address the broader opportunities for foundational work in behavioral health, for prevention, and for training too. And so with that, that's really what sets the stage for us all coming together to look toward innovations, to look at how can we all come together to think about ways to address the access gaps and to really raise the quality of care regardless of the geography, where any kid in Kansas or Missouri has the same chance of success and the same chance for good behavioral health and overall life outcomes. And what goes along with that is what we're seeing with, again, really trying to look at some of the public health and population health approaches. So really looking at 50% of our health more coming from community and physical environment factors, and looking at how can we all work together to positively impact those factors. Dr. Correll, did you want to add something? I'm sorry if I interrupted.
No, not at all.
And so that's kind of the background that comes to Telehealth Rocks. We've even kind of evolved with our name. We're now regional outreach to children, regional outreach to communities, kids, and schools. So more taking that broader approach. I really came from that top left square with clinical services. So I know many of you more from that telehealth hat. I'm a child psychologist, so really coming at it from how can we deliver our very strongest interventions when children are struggling with depression, anxiety, and other concerns. But with that has opened the door to these other really exciting, how do you get and support children before they end up in a psychologist's office? How can we all work together? So I'd love to work myself out of a job where we're really supporting the family, where there's not as much harm being done and there's not as much need for clinical services. You'll hear from Robert Stiles, the director of the Telehealth Rocks program, and many of the exciting things that he has done in both Kansas and Missouri. It's really nice to be paired with a public health expert because it's really pushed us to more think and put into practice more student prevention efforts, more training. And then what we're especially talking about today, making sure that our base is really strong, that community engagement and family support is really underlying all that we're doing with this work. We're really, we'll see this slide in just a minute, but really conceptualizing that engagement and family support as part of mental health, and that being part of the whole set of services, and really the necessary precursor to all the other types of strategies. Robert, again, I can't see you on stream, so I really welcome you to add anything else on this slide. I know that you have a lot of passion in a lot of these areas.
I would just say I was the director of primary care at the Kansas Department of Health and Environment, right? So I was responsible for National Service Corps shortage designation. I've lived the world of workforce. And then I went and ran FQHCs. We are never going to have enough providers. You know, if we keep getting kids into crisis or keep, you know, we have to start working upstream. You know, that's, and, you know, like I have a master's in public health. So, you know, that whole upstream idea of public health. So this is just, and I think sometimes we don't think in mental health, the biggest sort of change we've made is this idea that focusing on social determinants of health, focusing on things like food, housing, clothing, meeting family needs, supporting families, those are all behavioral health interventions. Unfortunately, our system doesn't pay for those. They pay for services. But, you know, that's what I think we're all trying to do to get the system to change. So that's all I have to say about that.
I think kind of along with that, we're especially looking at addressing social determinants of health needs. In the triangles there, you'll see the community health workers that are being placed in schools, which Robert and the Eldon partner really innovated early on. And then we've had other early adopters with some of that social determinant work here in Kansas with Dr. Correll and leadership with early work in school-based mental health overall. This is saying something similar in the same way. With all our work, we're gathering social determinants of health information. We're using the Arizona Self-Sufficiency Matrix to look across 18 dimensions of social determinants of health. I think with what we're doing, you know, we can call it social determinants of health in some settings, or work that we're doing in research, we're more leaning into social determinants of education. In our school-based behavioral health hat, the lingo is social indicators of health and education. And then, you know, in my world of mental health and child mental health, we may be talking about social determinants of mental health. It's just my reminder slide that we're all really talking about the same thing and making positive impact in helping children and their families with the 2-gen approach to really address some of the social needs around, do I have a warm bed? Do I have a consistent roof over my head? Do I have predictable food? All the sorts of things that I know many of you on this call really have deep knowledge about. So that's a key component. And I think as we're talking together, it makes sense how all that feeds into, you know, how am I feeling today? And ultimately, how is my mood and how am I protected from some of the more concerning aspects of behavioral health when those things aren't there, really being at risk for poorer outcomes.
I think it's important to add that if you're going to work in education, we're talking a little bit today, and we've invited 2 of our school district partners to be here. You know, one of the things, and I've been talking about it this week, you have to learn each other's language. We do talk about the same things, but we use different language. And one of the things you'll see when we get to our vision and mission is we talk about success because we've decided to choose a word that's applicable across all the environments that we work in, because schools are about success, health is about success, mental health is about success. So I would say it's really important to learn the language and the culture. If you're going to interact with a local community, we talk about that when we talk about working with people from different cultural backgrounds, but we also have to talk about the culture of the types of organizations and communities that we work with. And schools are a culture. Schools have a language, and we have to be able to translate our language to theirs.
That's an awesome point. I appreciate, that's a really good reminder. I think we're especially trying to frame everything from a strengths-based approach to, for me as a child psychologist, it fits really nice with our culture, but then really making sure, and our partners are really good to help us make sure we're framing things in that success language and looking at what we can do and what we can do together with incremental change, and looking at that positive side, not just deficits. In terms of more as we're translating some of this to proposals and kind of our thinking about how social determinants of health may impact broader mental health outcomes, we really have leaned into Shim and Compton's model. I think it's really a useful model to help us kind of think and put our work into context. A lot of our focus is on kind of that middle section and thinking about how we address those social determinants, but then thinking about then how does that ripple out? This is talking about more, if those aren't addressed, what are the pathways that lead to worse outcome? But if they are addressed, that's also then opens up the pathways that lead to better outcomes. This is saying it a little bit different. This is like Robert was mentioning before. We try to translate what we're thinking, and with our school and community partners, think about how does that fit with education and school language. So again, I know folks have encountered this before. The multi-tiered systems of support is really a common model utilized in education settings. As well as the school-based mental health settings. So we really try to talk about our work within the tiered system and look at family, school, and community partnerships at every tier. I think we're, again, trying to make sure we're saying out loud with all the work, and then also the proposals and the research that base is mental health. And underlies everything else. An important addition to our team, including the educators, the parent, the behavioral health, all those folks who are interested in this, in the outcome and the well-being of students. We've added school-based community health workers. Again, this work's been going on longer than Telehealth Rocks has been doing it, but it's one that we're hoping to amplify and to have opportunities to increase their work in our Kansas and Missouri schools. I like this graphic, and again, the teams, many on the team are on the line who helped create it. So thank you for this. I think it really helps kind of show, it's kind of that the bridge between communities and families and some of the specialists and some of the more tertiary care, and looking at ways and ways we can all communicate, and being that person who helps navigate that, and really is that person on the ground that can help really quickly connect dots between what is the need that the family has today and what are some of the resources that we all know together can help meet that need. And then I know our partners will talk more about that as well. Robert, is there things that you would want to add?
No, other than the one thing I think we sometimes get wrong with interventions is we think, okay, the CHW is the intervention. The intervention is how do we create a community and a school and an environment and get everyone working together to create an environment that's good for kids and families. The CHW is a person that helps facilitate that because it puts someone in place. But you could stick a CHW in a school or a community and not have any impact if you aren't also doing that sort of community engagement, community development, family development, all of that other work. The CHW is a person. It's the sort of global approach to change that really impacts meeting kids and families' needs.
Robert, can I expound on that for a second?
Yes, please.
Yeah, please, Aaron. Aaron is the Director of Special Services at Eldon School District in Missouri, which one of the things we did kind of innovative with our approach and our funding is they are our TA provider for education. So we are a Kansas-based program, although we are rapidly expanding into Missouri. But when we wrote what's called the AWARE grant, we told the feds we wanted this school district that had CHWs and had this process longer than anyone to be our TA provider. So it's kind of weird why is a Missouri school district here today? Because they're literally the people, they are our experts that we are paying to be our experts on this model. So please, Aaron, just wanted to preface that.
Yeah, and we appreciate all the support. So obviously, from a school side, instruction is sort of one of the paramount things that we think about all the time. And like direct instruction, like we have to teach kids how to walk down a hallway. And we know that if we teach them how to walk down a hallway, they know how to walk down the aisle at Walmart without being, in people's way. And we know that if we teach them how to break down a word, they can break down all words. Like you don't teach a kid how to read every single word they'll ever encounter. You teach them the fundamentals. A CHW is mistakenly seen as this is a person who just helps provide resources a kid needs. But we can fill a closet with the resources a kid needs. When they're doing it really well, they're also working on direct instruction with that student about, I know this was an adversity. Here's how you handle adversity. Here's how you seek resources. Here's how you talk to people. Here's how you say thank you for the support you were just given. Here's how you explain, like, it's bigger if you do it right than handing a kid a pair of shoes. The shoes are the really, really important piece, but more important is the direct instruction of how do you start to overcome your own obstacles and work us out of jobs. And I just wanted to make that point because I think that that's oftentimes an overlooked component of what a CHW does is that interaction in the culture building and the direct instruction of tough moments. So there you go.
Yeah, that's an awesome point. It just ripples out like all that, the skill then applies to multiple things. That's an awesome point. Aaron, since you chimed in, I know you may mention this later, but it stood out to me when you talked last week about it's when you look at who you are looking for in someone who is going to be a school-based community health worker, you really helped us better understand, it's not just the position on paper, it's the passion in the community. I wondered if you might say a couple words on that too.
Yeah, thank you. So, I mean, Eldon does some things sort of our own way. And one of the fundamental things that we think is vital is you're hiring the person, not the resume. And who are they at their core? What are their beliefs? Do they have the passion and the heart and the things that we really need? And not that experience and the credentials aren't vital, but the first thing that we identify is what are we addressing? Like, what is the thing that we've got to overcome? What's the issue? And who is a person who has a massive heart for that I don't have to train to care? That's the thing they bring in with them. And now we can talk about some of the resource building and the things that they may need a little bit of support in. But I think you have to know your community and you have to know your people. You know what I mean? So like, for instance, I need to hire a parent educator. Well, I'm looking at who are people that I really love the way they communicate with kids and parents and feel comfortable going into hard homes and are okay to, you know, to do the things that some people may feel uncomfortable, and they may not have the same credentials, but I know that they've got a heart to sit in that room and say, I know parenting is hard, and let me talk about some resources and connect them with the CHW and see the bigger picture. And I think that's where we have to look at what are the things that we are struggling with? What's the stuff that's keeping us up at night? Who else wants to take on that challenge? Let's empower them.
Thank you. That's really helpful. Thank you. So one thing we heard from our community advisory group of partners that was one of those things fallen into things keeping folks up at night is some concerning increases in having kids at school and getting enough, you know, dose of education and time in school to have the many benefits that being part of the school community gives kids. So one avenue that we're pursuing is a grant that's looking at what's the impact of school-based community health workers on chronic poor attendance. And then kind of looking at what does that look like? You know, hearing from partners that school-based community health workers are kind of naturally seeing a lot of children and families struggling with poor attendance, because a lot of times those are important barriers to why kids aren't at school. So we're through. We're about halfway through phase 1 with the HERE trial, and that's been gathering input from our stakeholders about just how they would like to see that intervention and what they think is important with a school-based community health worker intervention around chronic poor attendance. And then we'll hopefully be able to bring back some information to this group in about a year about the feasibility trial and seeing what was the impact. You know, what are we seeing as we test that out in one of our schools? Is it an intervention that makes sense to pursue some more with school-based community health worker, or are there some things we need to fine tune? With that, I really want to hand it over to you, Robert. And kind of help us understand the program side and really the many partners that you are working with.
Well, thank you. And so I guess my side of the thing is, you know, I do have a public health background, but I'm, you know, not that Eve-Lynn's not practical, but mine is the day-to-day, how do we make this work? I mean, I'm the program director. And so the first thing to know is that we did things. Eve-Lynn talked about changing our name. One of the things we did is we dropped KU from our name. And one of our recent successes was we recently had a web put together a 3-minute video on school CHWs that interviewed CHWs and other staff at the Coffeyville district, where Dr. Correll, the superintendent, is here today, but also from the Fort Scott district. And I was so pleased that in an entire 3-minute video, KU's name didn't come up once, because ownership and this project is about the partners. So we went to a network model. I have a long history with the Office of Rural Health Policy, which does rural health networks, and really has, if you ever want to look at how do you do a true network, their rural health network development and implementation process is, I think, one of the best. So it's been about 1.5 years now. KU has 1 vote. Everybody has 1 vote. So these are the partners. We do have Kansas government. We've managed, because of an AWARE grant that we have, which is Advancing Wellness and Resiliency in Education, which normally goes to state departments of education. We were the first grantee in the country that was not a state department of education. But that required, and we're pleased to be partners with the Kansas State Department of Education and with the Kansas Department of Aging Disability Services. Since then, we've developed a very strong relationship with the Department for Children and Families. We work very closely with the Kansas Department for Health and Environment, which is over CHWs and credentials them and has Medicaid. We work with a lot of statewide partners. Most importantly, we work across education. You can see the school districts in Kansas as well as the school districts in Missouri that we work with. We bring in all the healthcare providers we can. One of the things that's really interesting is our CHWs are in 3 districts. Our CHWs are employed by an FQHC, Community Health Center, Southeast Kansas. In 3 school districts, they're employed by a mental health center, Fort County Mental Health Center. And in 1 school district, Coffeyville, here in Kansas, they're employed by the school district themselves. So we'll work with whoever. And one of the things when we talk about helping communities with this model is helping them find their partners. And then, the biggest development that we've had is we've really moved into child welfare. We've really moved into juvenile justice and youth impacted by the system and families impacted by systems. And our real belief is that we've got to have everybody at the table. We spend a lot of time talking about coordination, not creation. We don't believe in creating things. We believe in sort of adding to or trumpeting those things that work. Not one of these ideas, including put a CHW in a school, was a new idea. It was just an idea that responded to what people at the local level wanted to try. So next slide, please. And also, Aaron and Dr. Correll, tell me where I'm wrong. The idea of talking about partnership in front of my partners is ridiculous. The biggest question is why do you put up with me? So I really do believe that partnership is only and always about doing what you can't do alone. If your organization can do it, then you don't need a partner. We try to find the big stuff that takes all of us. And then involving others is also means engaging others. But I would say actually engaging others leads to involving others. I mean, it's both sides of that coin. Ownership is so important. Dropping KU from our name was important to me because this is not a KU program. KU Med getting 1 vote, just like every other organizational member, was very important to me. That this is, it is locally community-led, that this is about all of us figuring this out together. Next slide, please. So it does take everyone. I truly believe we can change things for kids. I think sometimes people think I'm naive, but I've been at this forever. I was in government, I've run FQHCs, and these people that are on the call, Dr. Correll, he's the person I went to back in 2011 when we'd put a medical clinic in Coffeyville schools and the kids that were coming to the nurse's office didn't have medical needs. So he was assistant superintendent who, and it was the school nurse that said, we need a therapist. So then I went to the school and thought I was going to be run out of town and said, what do you think about putting a therapist in the school? I actually went to the National School-Based Health Alliance that summer and was told by the CEO of the National School-Based Health Alliance that you can't put a therapist in a school, not integrated into the education process. And then when I was in Missouri, I started working with Eldon. We put a therapist in that school, and really through working with them, the conversation came to, we got to work on things like food, clothing, and housing. So at that point, the state of Missouri was funding CHWs and clinics. I, as an FQHC CEO, right, I had a school clinic. So I just put a CHW in a school. This was not new, but this was about everybody paying attention to everybody else and thinking of what might work. Next slide, please. I'm going to let you do that one, Eve-Lynn.
I'll go through this one quick. It was just a reminder slide that we have lots of different people at the community advisory table. You've described that already, Robert. This was just a slide that kind of dives into that and saying that you need lots of different perspectives if you want the strongest program.
And I think that's absolutely true. Next slide, please. So I ridiculously have been asked pretty often by the feds when grantees are having trouble with partnership. They can't get their partners engaged. For some reason, they asked me to go work with them. So this is a result of conversations. Actually, Dr. Correll was one of the people I asked. So the first time the feds asked me to go in and work with a grantee on partnership, I went to everybody I'd ever partnered with that I could think of and said, what's important? And what we came up with, you have to trust each other. You have to have respect and equality. You have to be prepared. I talked earlier about know the language. Don't talk from a healthcare perspective without understanding how that impacts an education perspective. Collaboration, communication, and you really have to believe in the same value. You have to be on the same page and want to go the same place. You may not know how to get there, but you have to believe in where you're going to go. So that comes into our collective vision. So we meet twice a year in person. We talk all the time. But every 6 months, we get together in person and we decide what we're going to do. So, and we've agreed this is our vision. So we really believe that we can create schools and communities where every child and family has the resources and skills they need to have the same opportunity for success in school and in life. And I'll just say briefly in this conversation, stay away from language that's loaded or that causes problems. This is an equity issue, right? We can talk about, I can tell you all the right language, but if this is language that's going to cause a problem, just talk about what you're trying to accomplish that doesn't use that language. So success, we can believe that all kids deserve a chance for success, that every child should have the equal opportunity for success. So go to the basics, talk simply, and get to the point. Next slide, please. So our mission is, I also believe that we don't create anything new, or that we should only create new things or put new resources in place where they don't exist. So we spend a lot of our time understanding what is happening and finding the good things that are happening and then helping foster them going broader and bigger. Next slide. So these are the values that we've agreed on, that we're going to be simple. We're going to be a big tent, everybody at the table, doing a few important things together, right? We're only going to do what we can't do on our own. It's inclusive, that it takes all of us, everybody who impacts children and their families. That's why DCF and juvenile justice, and I don't care who you are, if you have anything to do with a kid's success in life, if you have anything to do with families, you know, in February, one of the things that we were told to do, I was told to do as the director by our new network, was we got to get into community engagement, but also community development. Economic development is now one of our core concepts because it matters, right? You know, and 2-gen, I love that we're going back to 2-gen models after like a 4-year hiatus. And this idea that what you do for the parents leads to the success of the children. That if parents have a job, if you help parents with skills, if you help parents with their needs, you're going to help the child. Collaborative, everyone has an equal voice. Everybody has the same say. Every single organization has the same say. That it's responsive, that they tell us the local level is who makes the decisions, that people who are experiencing it every day tell us what to do, and we have to listen to that. That we have to understand that the only way people partner is by getting their own needs and their own objectives met. So everything we do has to be part of, you know, Eldon school district's needs have to be met. What Coffeyville needs have to be met. To be a partner and to be engaged, they have to be moving ahead with what is important to them as an organization. Next slide, please. It has to be coordinated. We have to, I spend most of my time on coordination. My biggest job is just introducing people to each other. You know, recently I was meeting with the Fort Scott district, and at the end of it, I said, what are you still missing? What are you still working on? And they said, we'd love to have a better relationship with DCF. And I said, well, that's easy, because when I first started working with DCF, one of the first things they said to me was, when we have a family in crisis, when they're hotlined, how do we get the schools at the table so we can talk about resources? So that was the easiest conversation in the world. I just emailed DCF and said, hey, Fort Scott District would like to talk to you. Do you want to have a meeting? I mean, sometimes I feel so silly. People think we're accomplishing something big. All we're doing is people who want to know each other and need to know each other, they know each other. We do create new models, right? School-based CHWs. That was really the first sort of educationally integrated CHW in the state. What's been fascinating is both the Kansas Department of Education and the Missouri Department of Elementary and Secondary Education are now letting school districts use state funds to put CHWs in schools. They're using their state mental health dollars. One of the things that we're not really struggling with, but we have to be very careful, we're aware of, is how do we help people understand this model that aren't part of our network? Because we have school districts in both states now that are using school-based CHWs, and we're just, you know, we feel like we're barely down this road, but we have the most experience. And then we have to be receptive. Change, change, change. My biggest belief is, and this is not a research one, but the way I do my job is I believe that we should try something, and then when we figure out why it doesn't work, we do what works. That's all you can do. You know, we can't get caught up in, you know, and I talk about that the situation, and you saw it early, the situation is so difficult for kids and families right now. I'm almost not sure how we can make it worse, right? And, you know, I, of course, don't say do things, you know, without thought and planning and care, but we have to do something because the current system isn't working. Next slide, please. So gonna pass off, and I'll let Eve-Lynn kind of lead this conversation. And also, I know Eve-Lynn and I have talked a bunch, but if people on the MARG call have questions, please speak up. But Eve-Lynn, if you want to, or actually, I could start. Sorry, I'm jumping on Eve-Lynn. She's used to this.
Oh, sure.
But
That sounds
Dr.
great,
Correll
Ryan.
and Aaron, I'm really interested from both of you. Let's start with Dr. Correll. So why are you in this thing? Why did you think we should be part of Telehealth Rocks?
You're muted, Dr. Correll.
Sorry about that. Like you had said, Robert, we had met years ago. I think it was probably 14 years ago when we met and brought the health care into Coffeyville. Like a lot of districts, we are a very high poverty school district, one of the highest poverty rates in Southeast Kansas and probably up there in the entire state of Kansas, with horrible health outcomes. Our students, our community, our county, just horrible health outcomes. We brought community health centers of Southeast Kansas in. We have fully functional, fully staffed clinics in all of our schools, and almost immediately our health outcomes started to improve. We were in single digits or so on immunization, just something as simple as that. And within just a few months, we were up over 90% in immunization. So just really looking at that health. Something Robert had touched on earlier was that the poverty rates and the intergenerational poverty. And so we've seen that in Coffeyville. This has gone on for multiple generations in Coffeyville. So it was, how do we address that? Having the healthcare available in school obviously helped address just that basic need. And then moving on to having behavioral health available in our schools was huge. We created an early learning center here in Coffeyville for this very same reason, just to look at that intergenerational poverty. If we can get these kids in our system earlier, we can address some of those basic needs. When we did this project, we needed donations of upward of over $2 million. Our community college came to the table immediately and offer scholarships for parents of children who were attending the ELC. So we're really able to target multiple generations at one time. I believe the CHWs have just really been the next iteration of that. When it comes to social emotional learning, we were at the forefront in our state for this and done a lot of great work in that realm. And Robert said it a little while ago, your language is very important, and so much so. Being a forerunner in social emotional learning, a couple of years ago, the SEL kind of started taking a hit in Topeka at our legislative level with a negative connotation going towards social emotional learning, which I chuckle to myself because we work on essential life skills, which really is the same thing. And when you do that, people love what you're talking about, but that word social in there. So we've really tried to take the social emotional learning terminology out of our vocabulary and replace it with essential life skills, because who can't argue with essential life skills? So again, going back to, I guess the actual question here, the CHWs were really just the next, it just made the most sense when Robert approached us with this possibility. This is what we need. We have so many resources available because we're a high poverty community, but navigating those resources can be very difficult for our families, and understanding what's available, where it's available, what's required to access those resources. So our CHWs jumped right in and helped navigate that. But even bigger, it's the relationships they're making with the families. We've struggled for years, as most districts do, with parent involvement, family engagement, and the CHWs are really helping to crack that nut open for us better. We've hosted a district-wide event for families now for 2 years in a row. And the first year we did it, the person that was in charge of putting this on was a little depressed on how many families showed up. And I told her this was one of the best events we've ever had. So for the first one, that's amazing what you're getting. And so now we've done it a second time. We've had more providers come to the table to offer their services here. And so I do believe it is helping those families see opportunity within the school and to feel welcome when they come to the school, because that CHW worker is in their house talking with them and getting them comfortable, because school can be an intimidating place when you're a family of poverty, when maybe you didn't graduate high school yourself, you've had a really tough run. Now your students having a behavior meltdown in the school, and they're asking you to come. So I think parents show up probably feeling a little defensive that they're in trouble because their child was having a meltdown in school. And now they're realizing that's not the case. We really do want to offer everything we can. And as Aaron mentioned earlier, I think some people always assume that, we're here to teach reading and math. And ultimately, yeah, we want you to be able to read and do math, but we want you to be a great member of society. And that is teaching you everything. When it comes to our 2 and 3-year-olds at the Early Learning Center, we have to bring them in and teach them how to stand in a line, how to keep their hands to themselves, all these simple facts that people overlook sometimes. So just giving them that foundation at an early age so they can be successful later on.
Aaron, what do you think? Where have you seen failures in partnership? And you can talk about our failure, I don't care. But I mean, like, what do you think when someone's working at the local level or working with a school, which, schools in rural communities, in every community, if you want to impact families and kids, a school is a great place to impact them. But what do you think is important in partnership or in working with someone like KU Med to accomplish your goals?
Yeah, so you sort of asked two things about, failure and then the partnership.
Well, you know me.
I think it's good. So to start with the partnership, first, from a school perspective, we get inundated with people who have great ideas for us, who want to tell us the next best curriculum, that if only you'll do this thing, every one of your kids will be proficient. And it's weird how many people have cracked the code, and yet students are still not proficient across the country. The reason for the partnership that works here is it's not about the program, it's about my kids, because there's 1,900 kids in this district that I love. Those are mine. You know what I mean? Like, that's my family, that's my community. And so it works because it's about us, not about somebody who has the magic answer. It's really about us coming up with our own solutions. And I think that was the thing that drove me nuts as a school counselor for so many years, is I was like, why is nobody else caring like I care or we care? And then it was, once we sort of got over the hurdle of it's not about everybody else, it's about what can we do. When somebody gives you the tool to do the thing you want to do, you do it with much higher level of intensity and fidelity. Then the failure part is actually kind of an interesting one to me. Like, so I'm going to, for a second, talk about the attendance. We've really attacked attendance. And I can tell you the qualitative side of, Troy graduated. And for you guys, that doesn't mean anything, but for our community, that means the world, because we know his backstory and how hard it was, and getting him into an alt school and convincing him why this was important and things like that. And so last Sunday, when he tells me I'm the first kid in my entire generation of family to graduate, that's a massive success. One of the failures is that for some families, they would rather homeschool their kid. And in Missouri, where it's an abomination of, once you say I'm going to homeschool my kid, there's no oversight whatsoever. You can do whatever you want. Nobody's checking. And so one of the failures is the realization of the escape valve for the families who weren't ready to overcome or weren't ready to deal with. And so by addressing that, there are some kids we've lost, and now we've got to go track them down and say, hey, I know you're not part of our school districts, but we still care about you. What can we be doing for you? And so it's like the failure is finding the other options that people have that we hadn't really considered. And now going back and addressing, how do we push without pushing that far? And how do we get this kid without getting their family to feeling like they're getting to that point? And so I don't even know if I call that a failure. It's just more of an eye-opening of areas that we didn't even know we needed to address. Does that make sense? Yeah, the language, by the way, I'm so glad you guys bring that up, because teachers are chock full of one more thing on their plate. And I'm telling you, if I said, guys, good news, there's a free lunch in the cafeteria for you right now, some of their first thoughts would be like, well, great, now I got to go find coverage so I can get to my free lunch. it cannot, I mean, one more thing is a lot right now. And so to be able to say, this is actually stuff where we're helping take off one more thing, and you have a partner in caring, that is massive. That helps avoid burnout. It helps administrators' time immensely. And those things are invaluable throughout the year, but especially, you know, you're talking May 16th. Man, that's career-saving stuff.
Thank you guys both. Sherelle, I know we're about out of time, so I'll hand it back to you. But thank you guys for listening to what hopefully something was helpful today.
Oh, many things were helpful. My only regret is that we don't have more time. I have so many questions. How did you find each other? How did you implement these things? So we definitely will need a part 2 after phase 2 is complete, and maybe we can even invite you two back. I don't know if you will be available then, but we'll try to find a time that works so that we can hopefully have a chance to ask more of those questions about your involvement in the program as well, because I know I'm not the only person with questions. So thank you, all 4 of you, for attending today.
I just want to say, Sharayla, thanks. I know several on our team attended, and I'm very grateful to them as well. Our bonus was our new video, so we'll just send that out to the group. I really hope people take a peek. We're proud of it.
And what was that one of the videos that
This
you
is the
sent?
video that doesn't mention KU once, and I'm very proud of that. So this is
Okay.
interviewing school districts, including Coffeyville, about YSEHW.
Okay. If you, people who are attending, if you go to your invitation, there is a 4-minute video and a 3-minute video. Both of them are linked inside of that invitation, so you should have access to them already. But when I send out the video for this call, I will make sure that the videos are included in that email as well. Thank you, Aaron. I see you have included some information as well. Thank you. As mentioned before, there are some things in the chat about our next meet and greet. The Juneteenth Wellness Festival is happening June 14th, sponsored by the Center of African American Health. I didn't see any more flyers in the chat, but feel free to send them to me. The MARG bulletin will go out tomorrow. So thank you all for your time. What important work you're doing. I just have so much to digest about it as well. And as the former outgoing PTA president at my child's school, I have so many thoughts, and so many things that you said resonated with me, since we work with caregivers and teachers, and we see the burden, and how can we really dig down into how to save the kids. And so that's what we all want to do, is just save the kids. So I appreciate it. Thank you, everyone. We will see you next month at our final MARG meeting for this fiscal year, actually. So thank you so much. I'll see you next month.
Thank you. Take care.
Take care. Bye.